Hello again. This is Non-Intentional Childhood Injuries, Part 2, Initial Evaluation. When a pediatric emergency occurs, we do a primary and a secondary assessment. But when they initially come in, you need to very quickly look at the child. Do they have an airway? Is it patent? Do we need to change their position so that they can actually get air in? Are you hearing any audible sounds that you shouldn't be hearing? That could mean that the airway is obstructed. Does it look like the child is having difficulty breathing? Either they're working to breathe hard or they've completely given up on breathing. Do they have flaring? Are they using their accessory muscles? Doing the once-over. What does their circulation look like? Are they pale? Are they dusky? Are they blue? Are they rosy red? What is the temperature of their skin? As you just reach to take care of a child, you can do a lot of assessment with your eyes and your hands very quickly. Just picking up a child and pressing in your thumb, you can see that cap refill very quickly any place on their skin. The pulses can either be very quickly done if you're very good at being able to access them, but that's not the first thing that you do unless this child is not awake and alert. If they're awake and alert and responding, you know that they have a pulse. And then you have to look at this disability feature. Are they behaving the way you expect them to behave? So in pediatric care, behavior, behavior, behavior. Know what they should be doing. Are they responding the way you expect? Are they responding to the environment? You come into an emergency room, these kids should be scared to death. If we don't have their parent right next to them, they should be screaming bloody murder. And I'm talking all the way up into adolescence. They're still, where's my mom? I want my mom. I'm afraid. What is their pupil response? Do they know who they are? Can they tell you their name? Can they tell you how old they are? And then are there any other obvious injuries that you need to deal with? Do they have a burn? Do they have a bone that's sticking through the skin? Do they have bleeding somewhere that needs to be stopped? So in pediatric emergencies, you need to review your CPR. You need to review how we address a foreign body aspiration in an infant versus a child versus an adult. In the beginning of your shift, whatever area you're working in, make sure that you locate the emergency equipment so that if it happens, you know where to go to get it. Somebody's job will always be to check the crash cart. If the lock is on, that means it's fully loaded. But if that lock has been disturbed at all, the oxygen tank isn't where it usually is, you need to look and see how much oxygen do I have in my tank, what is missing out of the cart. Because one day it's going to be you that is assigned to make sure it's there. And if we have an emergency, they're going to look at you and say, that was your job. We just coded a kid and we didn't have the stuff. That will be your responsibility. So we do use the ABC approach, and you can do it. Just keep training and keep telling yourself you can do it. So once again, what do we do first? Assess the airway, make sure they have one. Then we check their circulation. Are they shocky? And the signs and symptoms are going to be the tachycardia. Their skin is going to be cool and pale, and it may have mottling because of poor peripheral circulation. Their blood pressures will be down, and their cap refill is going to be greater than 2 to 3 seconds. Do a quick neurologic assessment. Are they awake and alert, or are they drowsy, but you can wake them up? We can arouse them by doing some type of painful stimuli, like pinching on their nail beds, or do we have to actually use our knuckles on the sternum? That is a more serious method of arousing a child. We're going to talk more about the Glasgow Coma Scale. You should all know this from 172 because I know Professor Kucharski is teaching it, and she told me when she taught you. So do review it, but when we get to neuro, it's going to be discussed again. We need to do our ABCs initially and the neuro check before we're going to address the obvious injuries. Now, everything is okay in that department. My kid's breathing, he's got a pulse. Yeah, neurologically, he's a little bit out of it, but I can still get them to answer me or they're responding appropriately. Now you have to do that quick once over. On a fracture, to assess a fracture, you have to see, do they have sensation below where the fracture is? Can they move the fingers? Can they move the toes? Do they have the pulse that's distal to the injury? And report any type of impairment, because if they don't have sensation and you can't feel a pulse, that means that it's an urgent trip to the OR versus, you know what, it's warm, I have a pulse, I have good cap refill, this can wait, okay? Because they may have a laceration that's wide open and spurting blood, and that needs to be taken care of. So it's very quick this stuff is happening. So lacerations, we're going to do a quick look at the wound and we are going to clean it after it is anesthetized. And then we have to keep track of the number of gauze that we use and lap sponges if we have to open up a pack of those so that we can estimate what the blood loss is. For burns, then we're going to see are they first, second, or third degree burns, and we clean, we will need pain management. So this is all in our first assessment and just getting started with what we're doing. And you know what? We haven't asked one question yet, because all of that stuff I just talked about, we're doing within about 5 minutes. That's where we don't work alone, and there might be a second or a third person who starts to ask the questions, because we need to know, when did this injury happen? Where did it happen? Who discovered this person? If there was a stabbing or a gunshot wound, well, who did it? Do we have any idea? If they fell, if they were hit by a car, how fast was the car going? If it was a motor vehicle versus motor vehicle, was it on a freeway at 70 miles an hour, or was it they were going 10 miles an hour and the kid came at him on a scooter? If they fell out of a tree, if they fell off a roof, if they fell out of a 3-story building, how far did they fall? How far away was a gun or a knife? Because it makes a difference in how much damage. And then what were the circumstances behind the injury? So if it's something like the kid was at the top of the monkey bars and all of a sudden they were on the ground, well, there's a lot of questions that can go on with that. Was the kid awake and alert at the top, or did the kid all of a sudden pass out at the top of those monkey bars and that's what made him fall? So you can see where, oh, he was up and running and somebody was chasing him and he lost his balance and he fell. That's a totally different pathway that we're going to be going and looking, because if he passed out up at the top, we had an event that happened first, then the kid fell. So it's probably a neural problem or it could be a metabolic problem. So this is why it's important to get these questions answered. So when you're prioritizing your interventions, you want to do a rapid assessment. So all these assessments we're asking you to do from head to toe with every single patient is so that you can get your flow down of how do we go about doing this. So you can get in there in an emergency and you are automatically doing it without thinking. And the more you do where people are normal, the more quickly you will recognize when something is not normal. The thing you want to try and do is keep a calm demeanor. We want to act, not react, because when you are reacting and everybody is looking at you or watching you or listening to you, and you are anxious, that raises the tension in the room. So we want to try and be as calm as can be. And like some of you say, you know what, I'm dying inside, but nobody's going to see it. That's kind of what you want to do. We work as a team with designated roles. And if it seems like it's chaos in there, somebody needs to take charge and say, you do this, you do this, you do this, and things go much smoother. Be systematic about your interventions. Check their cardiovascular status. Apply oxygen if needed. We typically have, when we're going to start IV fluids, we will automatically grab a purple top and a red top and a tiger top tube because we will get electrolytes, a blood count, and then the plain red top is for a type and cross match. We may not need that type and cross match, in which case we call that the type and hold, but at least it's at the lab. So we will administer IV fluids. We may have to give blood transfusion, and you need to monitor your urine output. So in these children, it's very important that once we have that IV fluid going, we need to make sure that they are peeing it out. And remember that if you don't have a kid that's peeing, we have to be very careful about hanging potassium. Prevent infection by cleaning the wound, pain management, and we are going to give them medication to make them comfortable, but not go completely under because we still need to continue our neurologic assessments. Don't forget about the parent and the patient, the coping and the anxiety. We get so caught up in what we do that we forget that there's a patient in the bed that's the victim of all of our good endeavors that we're trying to do, and they're scared to death. So an emergency admission, there's very little time to do the routine admission procedures, going through and when's the last time you ate, and did you bring any clothes to the hospital, and do you have any valuables? We're not doing any of that stuff. We are firing questions very quickly and getting answers. So focus on your ABCs at the beginning, weigh the patient, or we will use that Broslow tape to estimate what our drugs are that we need, dosage is. We have an emergency drug form that we can fill out. If the child can participate in any of their care, allow them to do so. We do have the parents in the room when we are doing any of our interventions, so get used to that. We even have them in there if they're coding. Ensure the privacy of the child. The older the child, the more this is important to them because that might be the only thing they remember. I was in the ER and I had on no clothes and there were 20 people in there and I was so embarrassed. So we do want privacy and keep these kids covered. So this ends part 2.